We'll go to the next talk. I invite Dr. Yogesh Vashisht to speak on advanced cholangiocarcinoma, regional chemo as an option.
Dear Chairman, I would like to express my thanks, especially to the organization committee, Dr. Balla, Dr. Rajneesh Singh, and Dr. Sanjay Mandal, inviting me to this event. So we have just heard from my previous speakers that we are putting surgically everything into these patients to having a R0 resection rate. But unfortunately, in the real world, if we look outside of the randomized controlled trials, the relapse rate after median follow-up 12 months only is over 60% in the group of cholangiocellular carcinoma. And the survival rates overall outside of the randomized controlled trials are unsatisfactory or not acceptable. So in systemic chemotherapy is not very effective in relapse cases or primary metastatic disease. And both trials, the BT2 trials and the ABC trials, with a similar systemic chemotherapy regime, demonstrated a survival of less than 12 months, around 11.5 months. Why is systemic chemotherapy not effective, especially in cholangiocellular carcinoma? Once the tumor exceeds a growth of a couple of millimeters, there are multiple factors that affect the penetration of the chemotherapy into the tissue. This is clearly shown for all types of solid tumors, but especially for liver malignancies. If we apply the chemotherapy intraarterially, we can demonstrate that the first pass effect before and behind the liver, there is a clearance of chemotherapy more than 50% and up to 95% depending which substance you are utilizing. As you can see that when applying chemotherapy, even utilizing less doses, lower doses compared to systemic chemotherapy, locally you will achieve much, much higher doses. And there's a science behind intraarterial chemotherapy and a lot of factors that you can measure. You can even come up with a formula and calculate the effect you are achieving with intraarterial chemotherapy compared to intravenous approach. Now the intraarterial chemotherapy can either be delivered as an infusion, means locally, you place an angiocatheter in the hepatic artery. That is when you have a low tumor load and located tumor burden, or the patient had severe comorbidities and cannot undergo an operation. And you can identify a primary supplying artery. It can be done with an angiocatheter, or you can implant an hepatic pod, and it is a short time infusion of 5 to 12 minutes with or without chemofiltration. In contrast, if you have higher tumor burden, larger region that you want to treat, you need a perfusion therapy. That is done nowadays with a balloon catheter. With the help of that balloon catheters, we can isolate regions in the abdomen and perfuse that region with chemotherapy. And the exposure time will be around 15 minutes only, and that is mostly done with chemofiltration to reduce the comorbidities associated with systemic chemotherapy. Now the perfusion techniques have been associated with high mortality and morbidity rates at the beginning, late 70s, because these were huge laparotomies, dissection of the retroperitoneum, or even when it was done intrathoracic, it was associated with dissection of all the major vessels. Nowadays, luckily, we have such catheter available, balloon catheters with 3 different channels, either tip of the catheter or on the side holes, and you can select, depending on which channels you utilize for the chemotherapy injection, which region will be perfused. You just require 5 to 7 centimeters of incision in the inguinal region, dissect the femoral vessels, and then you can combine the procedure with chemofiltration to bring down the morbidity rates. This is an intraoperative video, how it works. Here I go into the inferior cava and place the balloon catheter just above the hepatic veins. As you can see, there's a complete blood flow to the right atrium from the abdominal and below region, and accordingly you can go and place the artery in the aorta, and depending what type of perfusion you want to do, you place it at different levels. And below both the inflated balloon catheters, there is no natural perfusion. You have a complete stop blood flow, means warm ischemia. That's why you have to be fast. So as you can see, just with the force of your manual injection, you can reach the entire splanchnic bed. So we differentiate between hypoxic abdominal perfusion, where we treat the entire abdomen and the pelvic region. This is for cases where you have a diffuse peritoneal metastasis and lymph node metastasis that spread throughout the entire abdominal cavity. You place the balloon catheter, especially the aortic balloon catheter, at the hiatal level, and below that you have a stop blood flow. In the upper abdominal perfusion cases, we have patients where, like gastric cancer or liver malignancies, where the tumor burden is high in the upper abdomen. So we place the catheter below the celiac trunk and give the chemotherapy from the tip of the catheter. And after injecting the chemotherapy, we just go with the balloon catheter at the hiatal level to initiate a stop blood flow in the entire abdomen. And accordingly, depending where you place the catheters, you can also, with the same technique, treat the thoracic region or the pelvic region and even limbs. How does it function, works in reality? So if you want to perfuse the thoracic region, you occlude the catheter. After placing at the hiatal level, you wait for 15 minutes after you have injected the chemotherapy, and then you deflate the catheter and start with chemofiltration. For the abdominal region, you utilize the hypoxic condition, which is beneficial for penetration of the chemotherapy into the tumor tissue. So it is a slightly different. You occlude the balloons, and then you inject the chemotherapy, and you initiate for 5 minutes a complete stop blood flow. And after 5 minutes, you initiate with the perfusion machine an assisted perfusion. It's not the natural cardiovascular perfusion. That lasts for 10 minutes totally, and after 5 minutes of perfusion, you already start with the infiltration. So the effective time for the chemotherapy in the blood flow stop is only 5 minutes, and that's sufficient enough to achieve the results that I'm going to present you. So our experience with intrahepatic and Hilar Cholangiocarcinoma, I have intentionally taken out the gallbladder and distal bile duct cancers from here. We have 36 cases, and all had a metastatic disease, most prominent, as my previous speaker already pointed out, liver, lymph nodes, peritoneum, also lungs, where the sites where metastasis could be seen. I would like to point out that we were able even to treat ECOG 2 and 3 patients. 50% of the patients had an ECOG higher 1. And 30% had a liver resection previously, means these were the cases who relapsed, and the remaining had a primary metastatic disease, and 40% had undergone already a gemcitabine and cisplatin-based chemotherapy. And 1/3 of the patients consulted us with already placed Dutch choledochal stent. So in total, we applied almost 189 cycles. Out of those, 90 were in forms of arterial infusion via angiocatheter, and the others were predominantly upper abdominal perfusion, as I pointed out, because the tumor burden in the upper abdominal region was high in these patients. 50% of the patients had a combination of 2 types of regional chemotherapy, mostly combined with arterial infusion. For in patients who have a high tumor burden load, you can't go for perfusion immediately because you are risking a tumor necrosis syndrome. If the tumor responds well to chemotherapy, so you will have a septic condition after the perfusion therapy. That's why you initiate at the beginning with an arterial infusion, a low dose arterial chemotherapy, and you start to shrink the tumor. In terms of complications, we did not notice any mortality. The overall morbidity rate looks very high, but it was predominantly because of lymph fistula at the access site and due to wound hematomas. Because for this procedure, we have to completely anticoagulate the patient, and there were no grade 3 or 4 complications noted. The RECIST response, based on over 50 CT scans after each cycle, demonstrated that we had in total a partial response of 38%, stable disease in 48%. But unfortunately, obviously, like in real life, some patients do not respond even to perfusion therapy. And we could see that during the first 3 cycles, the partial and stable response was more evident. With increasing cycle numbers, the progressive disease became more evident. In terms of outcome, in the overall survival of these 36 patients was in median 23 months. And I want to point out the regional chemotherapy, that means the survival from the time point being undergone the first cycle of regional chemotherapy was in median 12 months. And this is higher than any other current standard in cholangiocarcinoma systemic therapy regime. So to sum up, regional chemotherapy in these patients is feasible. It requires a certain level of skills, but I think a surgeon who is capable of doing a liver resection is able to do the chemotherapy himself. It requires experience also in terms of dosage of chemotherapy and selection of the approach you are applying in which patients. But in total, if you combine this approach with chemofiltration, you have a very low morbidity, no grade 3-4 complications. Patients walk around the same day and are just in hospital for 3 to 4 days. You can even treat patients ECOG 2 and 3. Yeah? You will see that in all systemic chemotherapy trials, they only include patients ECOG 0 or 1. The quality of life increases rapidly, and the survival data, as I have pointed out, indicates that they are superior to the current standards, which is the BT02 trial and the ABC02 trial. I personally believe that this approach can also help us to get initially maybe unresectable disease in a likely resectable disease, and if we combine that in a multiple setting, adjuvant therapy, also perfusion therapy, surgery, followed by adjuvant therapy, we might have even better survival rates, more than median 3 years in the adjuvant trials right now. Thank you very much for your attention.
Thank you, Dr. Vashisht. It was very enlightening. Floor is open for questions.
I believe most are unfamiliar with this type of therapy. The issue is, you see, arterial chemotherapy had excellent results from Memorial Sloan Kettering. You may know that hepatic arterial infusion in the 80s. And they were just on the edge to apply it in the adjuvant setting when the systemic chemotherapy came up, which has proven to be ineffective in most of the liver malignancies. And now, not for cholangiocarcinoma, but for liver metastasis from colorectal cancer in Netherlands, the arterial chemotherapy has been currently tested in a national randomized controlled trial. And I am very much convinced that it will show benefit, it will show superiority over systemic chemotherapy. So they are, even in resectable cases, they are resecting liver metastasis, and after resection, they are randomizing into systemic adjuvants intravenously or hepatic arterial infusion. And if it turns out to be beneficial in terms of survival for the patients, Netherlands, Holland will implicate adjuvants treatment in colorectal metastasis to the liver with the first-line approach as an arterial approach. So that is something, I think there are not many centers, and previously only surgeons were doing it. But as my speakers pointed out, despite putting so much effort into surgicals, resections, may it be extended resections, portal vein embolization, or ALPS, whatever you take, we are just addressing a very, very small fraction of cholangiocarcinoma patients. Most patients do present with an advanced disease, and unfortunately, even R0 resection does not remain tumor-free for a long time.
So hepatic intraarterial chemotherapy has been on and off the radar for a long time. It came in the 70s,
Yeah.
colorectal meds, then it was in favor for some time, then it disappeared. Just like intraperitoneal chemo ports, which were in fashion, went off, and now we are back to HIPEC. So it's something which has come back. So my question is, you do it for only one session, right?
No, we repeat, sorry, I didn't point that out. We would, from our experience, we see the best effect after 3 cycles. But a cycle in arterial chemotherapy means one treatment is 1 cycle. So you treat 3 times.
Yeah, so you have a port in the inguinal region?
No, we access via, if we do the...
You access every time?
Yeah.
Okay. So that you don't have to put the catheters with the balloon. You don't have an indwelling catheter with the balloon. That's why, I believe.
No. You have to dissect the inguinal region for every perfusion therapy. Dissect the femoral vessels and bring the catheter in.
Why not a port? Just asking.
Because there is no technical device available with balloons that you can inflate and
Leave there.
Yeah. Leave
And what
there.
is the gap between cycles?
3 weeks.
One question. Yeah, Sandeep Chakraborty from Kolkata. My experience, I used to work in Birmingham, QE, right? We used to put a catheter through the gastroduodenal artery into the hepatic, common hepatic. And that was the one arm of trial. The trial was going on for, unresectable colorectal mets for the liver. And we have done quite a few. I don't know the result. It was, I'm talking about in year 2000.
Yeah.
And in my clinical practice in Kolkata, I have done 3 cases with irresectable. We put a portacat through gastroduodenal artery into the common hepatic and bring it out, and we use Gupta. And one patient, they survived more than 12 months.
Yeah.
So it's it might sound a bit anecdotal, but I have
This has
faced
been there, and people have been practicing it on and off. It was off favor, now it's back in favor. Very good data, new technique.
No, see, the issue with arterial chemotherapy is that the pharmaceutical industry has no incentive to test it. So we don't do it with any new upcoming fashionable compound. We use simply cisplatin, adrenomycin, mitomycin C. None of those is under patent anymore. It's very cheap, and it's available practically everywhere. And actually, there is no chemotherapy compound globally available that has an certification has been tested intraarterially so far. And the pharmaceutical industry has no incentives to do that.
Maybe if you devise a very high-tech indwelling port, you'll get the pharma back.
Actually, there is a system that has been introduced. It's called chemosaturation. So it is a double balloon catheter. You only have to place in the cava a double balloon catheter, and you isolate only the liver. But the disadvantage is to apply the chemotherapy, you have to place they place 3 angiocatheters in the left gastric artery, gastroduodenal artery, and in the hepatic artery. So, because that is it sounds simple, but there are some very, very little details that you have to follow. If you simply give the chemotherapy in the celiac trunk at a high dose, you may even induce a hemorrhagic gastritis, and it may even turn out to be necrotic in few patients. Or you may induce a necrosis of the duodenum. So this chemosaturation system is developed in a way that you can isolate the entire liver with a double balloon catheter, but you have to put 3 angiographic catheters, and so far the results have a median survival of 7 months, so it's not better. And I personally, as a surgeon, consider this an easy and feasible technique associated with low morbidity if you have the option to do chemofiltration at your institute, and practically everyone has that because a dialysis machine is available at any institute.
Sir, I have a question. Sir, as I understand, like we are giving intraarterial chemotherapy, and these patients either have received systemic chemotherapy before or would receive a maintenance chemotherapy systemically later on,
No,
right?
they had received, the half of them had received chemotherapy, but it was terminated due to progression.
So my doubt is, like, if we are giving it in locally advanced diseases, so it may be sometimes of palliative intent also. So in such a scenario, are we not adding the additional morbidity by doing the intraarterial chemotherapy, because we are already giving all the morbidity that is associated with systemic chemotherapy anyway?
No, you misunderstood. Don't give systemic chemotherapy.
Okay.
You know? You don't combine intraarterial and conventional systemic chemotherapy.
So these are ECOG 2-3 patients where you are not giving systemic chemo, if I got it correct.
And the time period after termination of systemic chemotherapy and begin with the intraarterial was several months.
Okay.
You know, the systemic chemotherapy was terminated in those patients because it didn't help them. It was not effective in those patients.
Okay, okay.
Yeah.
So, and the second part, what was your experience in terms of CAGB, sir?
Sorry?
In gallbladder cancer, what is your experience?
As you notice, I have asked my previous speakers what their experiences. Our experience is very poor. So, yeah, the survival rate is very poor. We don't have so many. I think, if I recall it correctly, I have 11 cases, and the survival rate was below 8 months.
Thank you, Dr. Vashisht. If there are no other questions, we will close this session. Thank you.